welcome Dr. Ryan Vandrey with Johns Hopkins University School of Medicine. He's here to talk about the science of cannabis policy and medicine here in Iowa. And it's his first trip here, and grateful to have him and share his expertise with us and help educate us here in Iowa. So, Dr. Vandrey, the floor is yours.
Thank you very much, and appreciate you coming this morning. It is on. Can you not hear me? All right. I think we're good. Technical difficulties, no problem. So I'm going to kind of talk a little bit about a handful of things. I want to talk about what cannabis is and what it isn't, describe some laboratory research that we've done here at Hopkins, and some patient registry studies that we've done to look at therapeutic effects. And then I'll try to tie that together and talk about how our research relates to policy and where I personally would like to see things go. So first, we need to get on the same page in terms of what cannabis is and what it's not. What are cannabinoids? So the cannabis plant is very chemically complex. It contains over 100 chemical entities that are unique to that plant, as well as hundreds of other chemical entities that are common to other plants as well. When we're talking about phytocannabinoids, or these naturally occurring cannabinoids, the two primary players are THC and CBD. CBD is also cannabidiol. THC is the chemical that we affiliate with the kind of high and the psychoactive effects of cannabis use. THC is also important in that, by definition, it regulates and determines what's hemp and what's not hemp. So cannabis generally contains THC. Hemp is cannabis that contains 0.3% THC by dry weight or less. Now, hemp varieties tend to be very high in CBD, and so it's important to distinguish between these two. They're the two most common and predominant phytocannabinoids. So before I move forward with differences between THC and CBD, it's important to note that there's an endocannabinoid system that exists in our bodies, and it regulates a lot of physiological functioning. The two predominant mechanisms by which the endocannabinoid works are the CB1 receptor and CB2 receptor. The CB1 receptor is abundant in the brain and the nervous system. CB2 receptor is located predominantly in the peripheral immune system in the gut, but is also located in small concentrations in the brain. Now, linking back to THC and CBD, THC mimics endogenous ligands that bind to these receptors and regulate physiological functioning. CBD does not, so there's a different pharmacology between these two molecules. CBD can modulate the endocannabinoid system indirectly, but it doesn't directly bind well to these receptors. So how is that important, and what does the endocannabinoid system do? The endocannabinoid system regulates a number of physiological functions and is very diffusely existing in many areas of our body, as I described earlier. And so this is why medicinal cannabis is being promoted and touted as something that can help so many different health conditions. It's very rare in medicine that you have that. So because the endocannabinoid system is kind of a regulator of sorts, it can impact a number of different health conditions. And so our current status, and this is a little bit old now, but it's still it's still very relevant. The National Academies of Science, Education, and Engineering published a systematic review of all evidence of the therapeutic potential of cannabis, generally speaking, about 8 years ago. And they found that there was conclusive and substantial evidence to support the clinical use of cannabis for treating chronic pain, multiple sclerosis, nausea, or emesis due to chemotherapy, and moderate evidence to support short-term use for sleep dysfunction. Now, shortly after that report was published, the FDA approved Epidiolex, which is a pharmaceutical formulation of CBD, to treat 3 different rare seizure disorders. So with that kind of foundation of knowledge, I want to kind of go in and start to talk about the research that we do at Hopkins. And one of the things that becomes very important is, kind of initially we're talking about cannabis as like it's this one thing, but it really is not. So we need to start talking about product types and the diversity of product types are very relevant to what the expected and resulting effects of any cannabis product being taken is. And so there's nuance and difference in terms of the chemical composition of the product. So whether there's THC mostly in there versus CBD, and that impacts the effects that the product's going to have on the person taking it. The intended route of administration, whether it's inhaled or orally ingested, topically applied, impacts the timing and the magnitude of the effects. The dose is going to impact the efficacy if you're taking it for therapeutic purposes. It's going to impact abuse liability and also the risk of adverse effects. And then the formulation impacts the absorption and excretion of the drug. And so what we've been doing in the laboratory that I work in at Hopkins is to kind of take those four things and to systematically evaluate them in controlled human clinical trials. And so I work with a team of investigators here that represent experimental psychologists, clinical psychologists, pharmacists, physicians. And what we've been doing over the last, 10 to 15 years or so is to run phase 1 clinical trials where we study different chemotypes, different routes of administration, different formulations to understand how these differences in product types that are really representative of the diversity of products that you find in a dispensary, and how they are impacted when the drug is administered to healthy adults under controlled conditions. And we evaluate things like subjective drug effects, cognitive performance, cardiovascular effects, and such. And so our protocol design is that we bring these folks in, we use a within subject crossover design, so the same person is getting all of the different drug products. So we're not really having different individuals taking different drugs. And we have them wait a week in between doses to make sure that the effect of one dose that we give them is washed out in between before they get the next one. So what I'll do is to kind of walk through what I think are the highlights of some of our experiments that I think are relevant to the discussion, really to show the difference between THC and CBD, and also the difference between route of administration, product types, dose, and things like that. So this first slide is going to show you the effects of a high THC cannabis flower that was given to people through different routes of administration. And so on the left-hand panel, you see a 10 milligram dose of THC, on the right hand, a 25 milligram dose of THC. And again, this is the same plant product that was smoked, vaporized, and orally ingested. And so the highlights here, if you just look at the time course of effects, if the drug is inhaled, you get peak drug effects immediately that kind of slowly decline over time. Whereas if you orally ingest it, you have a very slow onset of drug effects, but the peak magnitude of drug effects is sustained for a longer period of time. So the reason why that's important and why people will both inhale and orally ingest the drug in a therapeutic setting was going to depend on the symptom that you're trying to manage, right? And so if in the context, going back to why we think cannabis can be helpful, one of the areas is to relieve nausea and vomiting due to chemotherapy. So if you are nauseous and you're vomiting, an oral dose that you have to wait 2 hours to kick in is an inappropriate route of administration. Whereas inhalation, you get immediate relief of that effect, and it doesn't last as long. On the contrary, if you have a symptom like chronic pain and you're looking to manage that, you don't want to have a drug that has this big peak drug effect and then goes away quickly, and you're kind of on a roller coaster of efficacy. Whereas if you could take an oral dose that you have a sustained peak level for multiple hours, that's going to be much more beneficial. The other thing to highlight here is that the peak magnitude of drug effects between smoked and oral dosing is the same. It just occurs at different time points. And that 25 milligram doses give you a stronger drug effect than a 10 milligram dose. But note also that, a 10 milligram dose here is producing subjective drug effects. But when we look at cognitive performance, this is a memory task that we give people. And it's a very simple task in concept. It's having people see single-digit integers on their computer screen one at a time, and they have to add the last two numbers that they just saw together and click the sum of those on the computer screen. So it's literally 2 plus 3, 3 plus 4, 4 plus 2, that kind of stuff. But you have to remember the last two numbers that you saw. So at a 10 milligram dose of THC, you feel a subjective drug effect, but you're not impaired in your performance on this in any way. But as soon as we jump to a 25 milligram dose, you get severely impaired. And so out of 90 trials, when the drug is vaporized, you're compared to how you do at baseline, you get 24 fewer correct on average. So that's pretty substantial impairment of a relatively straightforward cognitive task. Another thing that we did is we replicated this in a different experiment where we used a newly developed iPad app called the Druid. And we tested the sensitivity of that app and detecting impairment, but also just wanted to replicate our findings. And we adjusted the doses in this experiment where the vaporized doses, instead of 10 and 25 milligrams, we gave 5 and 20 milligrams because, again, vaporization was a little more effective at delivering the drug effect than smoked or oral dosing was. And so we replicated our effects, and we showed not only that, but compared to a placebo or cannabis that contained no THC, the 5 milligram dose of vaporized THC and the 10 milligram dose of oral THC didn't differ on cognitive performance between placebo, but the higher doses, the 20 vaped and 25 oral, did. And so the dose becomes really important on not only on do you feel an effect, but at what level do you get impairment. So there are other acute effects of THC. So you take a dose. On the positive side, you can feel a subjective high, which is reinforcing and generally reported as a positive effect. You get increased focus reported by some people, increased arousal, improved sleep, pain relief, increased appetite, and things that we've discussed before. But there is also a dark side to THC, and if you push that dose a little bit higher, then adverse effects can happen. Adverse effects include dry mouth, nausea or vomiting. So even though it can be used to treat nausea and vomiting, if you push the dose too high, you get the opposite. Paranoia, red eyes, aggression and irritability. In some cases, rare cases, you can get acute episodes of psychosis. So again, it's important to understand that these effects are very dose dependent and also can be impacted by the tolerance or experience of the individual, their expectancy, and the environment that they're in. So thinking a little bit more about the likelihood of adverse effects, this is an experiment that my colleague Erica Peters ran, where she gave an oral formulation that contained either 2.5, 5, 7.5, or 10 milligrams of THC twice a day to healthy volunteers who were not cannabis users for 2 weeks in an inpatient setting. And what you can see is treatment-related adverse effects were mostly observed the first 2 days of exposure. But then after that, they were very rare. Also, the adverse effects were highly unlikely to happen at the 2.5 milligram dose, and most of these were driven by the 7.5 and 10 milligram doses. So it's going to be dose dependent, but it's also going to be experience dependent. And similar to other medications, once you kind of get used to the drug and you take it for a while, those adverse effects tend to dissipate with THC. The other thing to kind of point out, this is data from a recent study we did where we recruited people in Maryland who were new to cannabis and newly registered in our medical marijuana program. And we followed them over their first 8 weeks of using the drug. And so on the left-hand panel, what we have here is people rating how high they felt before and then after taking an acute dose. And then they also rated their anxiety before and after taking their dose of cannabis. And what you can see is people will report early in their use that they feel a little bit high when they take their medicine, but they also have significant reductions in their anxiety. And it's across routes of administration. The other thing to point out is that there's other clinical trials that have been done that shows lower doses of THC can be therapeutically effective, but also not cause subjective drug effects or impairment of functioning. So this is from an Israeli pharmaceutical company called Psyche, and they've developed a metered dose inhaler that delivers 0.5 or 1 milligram doses of THC, and they show significant reductions in pain in a clinical pain population. And in this experiment, you get reductions in pain compared to a placebo or 0 milligram THC dose, but you don't get subjective drug effects and you don't get impairment of cognitive functioning. So I'm going to switch gears now a little bit and talk about CBD and show you data from laboratory studies where we gave people 100 milligrams of pure CBD, either vaporized or orally, and compared that to high CBD cannabis that contained 100 milligrams of CBD and 3.7 milligrams of THC. So that's similar to, but a little bit higher than the concentration of what you have in hemp. So it's 3.9% THC, or sorry, 0.39% THC. And what we found in this experiment is that CBD by itself really did not produce any interoceptive drug effects, except for when it had that little bit of THC in it, and 3.7 milligrams of THC when it's vaporized. As I showed you before, a 5 milligram dose produces an interoceptive drug effect, but didn't show any impairment, and we kind of replicated that finding here. But when we think about a lot of the THC specific drug effects that people tend to feel, they don't report those with CBD, and really don't report those very much with the low dose of THC. So feeling like your heart is racing, having a dry mouth, feeling paranoid, having trouble with your memory really was not detected in this experiment. In another study that we recently completed, we did oral dosing of high CBD products. These were CBD oils that we manufactured in our laboratory, and the oils contained 100 milligrams of CBD. And then we had different dose conditions where we had 10 people get each dose of THC. One group got no THC, and then groups got 0.5 milligrams, 1, 2, 2.8, and 3.7 milligrams of THC. And they were given an acute dose under a laboratory setting. And so the first kind of, if you look at the x-axis here, up to 6 hours post-dose, we monitored people's cognitive performance, and we looked at drug testing outcomes. And then we had people take this same medication twice a day for 2 weeks, and then we had a 1-week washout at the end. And so you can see that there's really no cognitive impairment detected at any of those THC doses when combined with 100 milligrams of CBD at any time point in the experiment. But interestingly, urine drug testing showed positive drug tests for most individuals taking anything higher than 1 milligram of THC. Going back to our acute dosing of CBD, pure CBD in oral dosing, we evaluated the oral dose in different formulations. One was in a sesame oil, one was in an encapsulated, and one was in a pharmaceutical grade syrup. And we showed that the formulation greatly impacts the absorption of the CBD. And then those purple dots show that what CBD looks like when it was ingested in the oral syrup after overnight fasting. So that if you have food in your stomach, you actually get greater absorption than if you don't. So looking at CBD and THC in a topical formulation. So this becomes an important thing when you're looking at the relative risk of different product categories and the importance of route of administration. So in this experiment, we first purchased 100 different topical CBD or hemp products, and they contained varying levels of THC. We chemically analyzed these 100 products, and we picked the 5 products that were different in terms of what was in them, in terms of what the matrix was. So we had a patch, a balm, a gel, and a lotion. And then we also had a placebo, and that was just a lotion that had no cannabinoids in them. And we picked those products that had the highest amounts of THC in them from all of the ones that we tested. So we were looking to, in this experiment, to maximize the likelihood that we would see any kind of drug effect and any risk of positive drug test after using this product for 10 days. And so we had participants, healthy volunteers again, come into the laboratory, use it for the first time under observation, and we checked their blood and urine concentrations of these cannabinoids for their 6 hours after exposure. Then we had them use the product twice a day on their own out in the world, and we had them come back periodically to tell us if they had drug effects and to collect blood, urine, and saliva from them. And so this first slide here shows CBD and its metabolites at the top, and you can see that only 3 products gave us any evidence in blood that the CBD was being absorbed. And there is no detection of THC across the board in any of these products. So again, cannabinoids are very poorly absorbed transdermally. And what differentiated the three where we saw CBD was that those had permeation enhancers. So they had DMSO or an alcohol in them to kind of promote transdermal absorption. Now, in that same experiment, when we looked at these drugs, we really saw no subjective drug effects, no abuse liability. There was no liking of the drug, or really no drug effect detected at all. And there was no detection of impairment on any of 4 cognitive tests that we used, and no change in heart rate. So topical cannabinoid products really are very safe from an abuse liability and from an adverse event profile. And just to kind of highlight, even though we saw detectable amounts of CBD in some of those products, overall, compared to vaporized CBD or oral CBD, blood concentrations were minuscule. So I'm going to switch directions now and talk a little bit more about a different type of research that we do. So in addition to the controlled human laboratory studies that we do with healthy adults, we are interested in detecting and determining whether or not cannabis does have therapeutic potential and to try to add to the science there. So we've been working in collaboration with a nonprofit in Colorado called the Realm of Caring Foundation for almost a decade now. And collecting data from people in their patient registry. Those folks kind of just report how they feel on validated assessments of quality of life, of pain, mood, sleep, and other aspects of functioning. And we are able to kind of capture 2 groups of people from this patient registry. So the Realm of Caring, their mission is really patient and provider education about therapeutic cannabis use. And so sometimes people are already using cannabis when they come into the program or contact the Realm of Caring, and other people are really just looking for guidance and they're interested in using cannabis as a therapeutic, but they haven't yet started. And so what we do is we kind of take those 2 groups and have compared them on their ratings of a number of different health-related assessments. And when we do that, we find that the people using cannabinoid products, and these folks are predominantly using hemp products that are high in CBD, but most often contain low doses of THC. The cannabis users compared with non-users have higher ratings of quality of life, better pain management, better sleep, and less anxiety and depression compared to the non-users. And demographically, these 2 groups are no different. We also found that the cannabis users are using fewer other prescription medications, and they have less healthcare utilization, so fewer emergency room visits and fewer hospital admissions compared to the non-users. And these are very sick individuals, and the highest cohort here are children with rare seizure disorders and other forms of epilepsy. And so when we break out and we look at specific subgroups of people in this patient registry and their data, we looked at CBD using people with any form of epilepsy. And many of these individuals are still using kind of traditional anti-epileptic medications, and some of them are using CBD as an adjunct to that. We see no difference in seizure control, but we see significant differences in medication-related adverse effects. And so it could be that CBD is attenuating the adverse effects of the other medications, or that they're have to take lower doses of the other medications, which do have terrible side effects. But overall, we found significantly less medication-related adverse events in this population that was taking a CBD oil, and better quality of life. Now, another cohort that we looked at were individuals that were taking CBD oils, and their primary reason for taking those was to manage anxiety or depression. And what we see here is on the left-hand panel, you see people's self-reported anxiety. Again, this is on a validated assessment of mood. and people's ratings of depression. And so what we see here, we've got 3 different cohorts here. So this is an evaluation not between 2 groups, but the same individuals at different points in time of the study. So we have people do these surveys every 3 months. And what we see is people who are using cannabis and continue using cannabis show improvements over time. And when they're using cannabis, their ratings of depression is less than the people that are not using cannabis and never start. But the cohort of greatest interest here is this middle group. These are people who, when we first surveyed them, were not using cannabis, and then later on they started using cannabis. And you can see clinically significant and statistically significant reductions in both anxiety and depression over time. Now, when we look at what products these folks are using and what doses they're using, by and large, they're using over-the-counter retail or internet purchased CBD oils. And the next most common is inhalation of cannabis flower. When we look at the CBD oil users, their mean daily dose was 79 milligrams of CBD, and their mean daily dose of THC was 3 milligrams. So again, coming back to that Israeli study, you don't need high doses of THC to get therapeutic effects, and oftentimes you can get therapeutic effects at low doses. And compared to Epidiolex, this cohort is there's a large cohort of individuals with epilepsy here, and a 79 milligram dose of CBD is far less than what kids usually take when they take Epidiolex. So that's usually in the hundreds, if not thousands of milligrams per day. So when you have these full spectrum products with a little bit of THC, you get good therapeutic effects, but at doses that, as I showed you in the laboratory, are not likely to produce much in the way of any subjective drug effects. People are not feeling high, and they're certainly not impairment-inducing doses. But that doesn't mean to say higher doses of THC could not be therapeutic. This is data from that Maryland cohort study I described earlier that shows that people taking high THC products, and again, these are adults entering the Maryland Medical Cannabis Program. They're new to cannabis. They've not been using it prior. And we see significant and clinically meaningful reductions in both anxiety and depression that is sustained for up to 6 months. Another therapeutic area in which cannabis is often promoted, and the most common reason it's used is for pain management. This is a study conducted by my colleague Johannes Thruel, and he evaluated people who used both cannabis and opioids to manage chronic pain conditions. And when he surveyed these folks and asked them, on days you use certain medications, what level of pain relief did you get? And so when they used both cannabis and opioids, they had the greatest level of pain relief, followed by use of cannabis only. So they skipped their opioids that day. And then third was opioids only. And so this is a demonstration, again, that using cannabis in combination with opioids can produce greater pain relief. And multiple studies have also shown that people, when they combine opioids and cannabinoids, there tends to be an opioid sparing effect. So you get lower doses of opioids and better pain management. So to kind of summarize what I showed you from the research is that THC is fairly effective and shows promise for the treatment of a number of health conditions. It's important to note that it is an FDA-approved medication for the treating of side effects associated with chemotherapy and other wasting syndromes. And it's been approved and on the market for 40 years. The effects are dose dependent. They can be both positive or negative, but it can be impacted by tolerance, expectancy, and the environment. And that doses up to 2.5 milligrams of oral THC or 1 milligram of inhaled THC really show no difference from placebo on subjective drug effects and don't cause impairment of cognitive functioning. And the FDA experience, or knowing that there's been an FDA-approved formulation of THC for 40 years, shows that that kind of product has very low abuse liability. If you talk to law enforcement, you'll be hard-pressed to find any case over 40 years in which the FDA approved dronabinol or synthetic THC has been diverted and abused by somebody. And again, thinking back to our doses, the doses of dronabinol that are approved by the FDA, it starts at a 2.5 milligram dose, goes up to 5 and 10 milligram doses. And when you look at the package insert for dronabinol, the maximum recommended daily dose for either of the approved indications is 20 milligrams per day. So to summarize what we talked about with CBD is that CBD is not like THC. It doesn't produce subjective drug effects. It doesn't cause impairment. It is FDA approved as a medication to treat multiple seizure disorders, but it also shows promise for the treatment of other health conditions such as autism, anxiety, depression, and PTSD. It really, in multiple studies, it's shown to have no abuse liability, and it doesn't cause subjective drug effects or impair performance at doses below 1,500 milligrams. But again, keep in mind that those are not the doses that people are typically using here. They're usually using about 25 to 50 milligrams at a time. And in our observational study, a total daily dose of 80 milligrams. So how does this all relate to policy, and what do we think about? In no circumstance do I think that any type of cannabis product or hemp product should be available to anybody who's not an adult. So any use by anybody under the age of 18 should be under adult supervision. And I think THC dose restrictions are appropriate, but it needs to be specific to the product type and tailored to the environment. So when we're talking about hemp policy regulation, it's important to know and to consider the formulation of the product. So I showed you in our data daily administration of topical products of up to 8.5 milligrams of THC per day showed zero absorption of THC into the blood, showed no drug effects, showed no impairment. And that is very different from oral or inhaled dosing. And so regulation of THC content in a topical product just doesn't make sense. And the formulations of these products, being in a gel or in a skin cream or a lotion, is not a matrix that anyone could easily extract the THC from and use it in a different way. You can't put a glob of skin cream in a pipe and smoke it. It just doesn't work. So switching to oral dosing, oral full spectrum CBD oils are the most common form of people using hemp products for medicinal purposes. Again, in our cohort study that we followed, the average daily dose of 3 milligrams of THC resulted in a significant health improvement for people using for a variety of health conditions. Adverse effects are very rare and mild in that population, but do occur. But typically, if you look at on aggregate, the likelihood and severity of adverse effects from those medications across people were less common and less severe than for patients taking alternative medications for those same health conditions. So you have to keep the entire full field of view in mind when you're looking at the risk benefit of a CBD product that contains trace amounts of THC versus the alternatives. So I think the key point and the reason that I've been asked to come and speak here in Iowa today is the concern about policy related to total THC package limits. The current policy is that there's a maximum of 10 milligrams per package or per container. And thinking back to our cohort of people taking CBD oils, they take an average daily dose of 3 milligrams. That would mean that these folks, again, caregivers of kids with seizure disorders and with severe autism that greatly benefit from these CBD oils, they would have to go to the store and buy new medication every 3 days. And that's just a terrible burden for those families to bear on top of the burden that they already have for taking care of very sick individuals. And just to kind of put that in perspective, imagine if you have a cholesterol medication that you take every day or a blood pressure medication that you take every day, and you were limited to a 3-day supply for the rest of your life. So managing chronic disease and being required to buy your medicine every 3 days just seems unreasonable. And then also keeping in mind, again, that THC is an FDA-approved medication, has been so for 40 years, and there's really no street use of that. And then the starting dose is 2.5 milligram, goes up to 5 and 10 milligram doses. And really, there's no adverse effect profile of people using that seems any different than a number of other pharmaceutical drugs. Um, so how do we reconcile all of this, and what else do we consider? Inhalation has the greatest risk for abuse, but again, at low doses, it seems to be manageable. But my understanding is that that's not really an option here. But I want to encourage people to kind of think about that, because again, within the medical cannabis access program, inhalation, I think, should be available given the need for immediate relief in certain health conditions. But again, dose should be managed and appropriately considered. The other thing related to kind of the abuse liability and the risk of allowing higher total THC concentrations in CBD oils is that just economically, it's not likely or even reasonable to think that a teenager would go and become addicted to a high CBD, low THC oral dose product. These products are federally legal, and I'm unaware of any individual case where a teenager was taking high CBD oils and drinking the whole bottle, especially considering that they cost $150 to $200 a piece. It's just not sustainable, and there's too many alternatives that are much cheaper and much more effective available to them. So again, what I recommend that is done is that there's investment at the state level into research and education for patients and providers about this, and to keep in mind that if the state maintains policy that prevents access to medicine that patients need, and limits these things, then people are going to find these drugs elsewhere. But in my mind, the greatest harm associated with the use of CBD oils is the use of unregulated products. So unregulated products, which can be purchased very easily from the internet, are not quality controlled. And there's a huge variation in the quality of those products. And while you can get products from reputable distributors, those reputable distributors will not sell in a state that has banned their products. But the folks that will are the ones that are not taking care and doing due diligence in their manufacturing. So the risk there is that you're exposing very sick individuals to products that either don't have the medicine in it or don't have accurately labeled amounts of medicine, and they're going to suffer as a result. And those products have also been shown to contain harmful contaminants. On the abuse side, if you have a ban against these products containing THC, people that want THC have ways of finding it. And again, they're going to find it through unregulated sources that are going to be putting those folks at risk of contamination, or they're going to go to a neighboring state that has access. So I will wrap up with kind of just a summary and the story that really kicked off the importance and the potential of CBD and hemp products for health and wellness. And that's the story of Charlotte Figi, who is the center of a documentary done by Sanjay Gupta, surprisingly 12 years ago now. If you have not watched that, I highly recommend that you do that. And it really is a game changer in terms of how you view these things. So with that, I want to acknowledge that I don't do all of this work. I do this with an army of people who are very intelligent and very driven, and with tons of support. And then here's my contact info for anybody who's looking at this as a video recording and doesn't get the chance to ask me questions now. Please feel free to reach out to me and ask questions. I'm happy to help.